What's up everyone, my name is Bo from Buzzwords Med, and today we're going to run through the pneumonia quiz on our website. So, if you ever wanted to get to this quiz, you would come to buzzwordsmed.com, ace the boards, practice exams, and it's one of the 4 exams currently out, Step 2 ID pneumonia. Alright, so let's start. So we have a patient present, altered, after being found down in the park. Her medical history is significant for HIV. Her known allergies include sulfa drugs and penicillins. Her chest x-ray is significant for bilateral infiltrates. The most appropriate treatment regimen in light of this information is 1. Pentamidine, 2. No treatment, 3. Glucocorticoids and macrolides, and 4. TMP sulfa. So the first step of this question is, what does this patient have? And so we have a couple hints. They're found down, they have HIV, and they have bilateral infiltrates. So what are you thinking about when you see someone with HIV with bilateral infiltrates? That's right, PJP pneumonia. And what's the first line treatment for PJP pneumonia? TMP sulfa. Fantastic. So you click that answer, right? Wrong. Why? Well, in this patient, specifically, they have a sulfa drug allergy, as you can see here. So, in light of that information, the best choice is pentamidine, which is an alternative for TMP sulfa. So, pentamidine was the correct answer, and we would continue on. If dapsone was an answer choice, that could also be a correct answer, as that is also an alternative to TMP sulfa. And again, that was for PJP pneumonia. So, second question. A patient with COVID pneumonia on standard COVID and ARDS therapies begins worsening with new fevers and hemoptysis. CT scan of the chest reveals intrapulmonary nodules with surrounding opacities. The next best step is, and I have an example of the nodule, here it is. Here's the nodule with surrounding opacities here. Fantastic. So, is it glucocorticoid therapy? Is that what we need to give this person? Is it IV voriconazole? Do we need to anticoagulate them? Or do we need to give them vanc and zosyn or piptazone? Well, this patient has COVID, we know that. And right now, the classic treatment for COVID and anybody in ARDS is steroids, at least circa 2020. So we've been giving this patient a lot of steroids in light of their COVID, and now they're getting worse with new fevers, hemoptysis, and an imaging finding with a nodule and opacification around that nodule. So, glucocorticoid therapy? Probably not, since that's what we've already been giving them. Therapeutic anticoagulation? Probably not. It's not really indicative of a PE. We have no signs that this person has a PE, although people with COVID are very hypercoagulable, and therefore not a horrible answer choice. We'll just leave it be for now. IV vanc and zosyn, broad-spectrum antibiotics, often not the right answer on these exams. If you were worried about sepsis of unclear etiology, among other things, in the wards, this is what you would do. But on the exams, I would find it difficult to find a scenario where you use vanc and zosyn. So the correct answer here is actually IV voriconazole. This patient has grown a fungal infection, which is actually surprisingly common now in these COVID patients because of their high-dose steroids and subsequent marginal immunosuppression because of the steroids. So if we go back to the image, you can see here this is the classic halo sign for aspergillosis. So you have the opacification and then a lighter opacification around the edges, known as the halo sign. So the answer here was IV voriconazole, and that is in the setting of aspergillus infection. All right, hope that makes sense. So, problem number 3. True or false? Early antibiotic treatment of strep pharyngitis can prevent rheumatic fever, but not glomerulonephritis. So this one should be a gimme. It's either you know it or you don't. The correct answer is true. So early antibiotic treatment can prevent rheumatic fever, but not necessarily the glomerulonephritis. That is true. Problem number 4. A patient with a history of cirrhosis and CHF presents obtunded and hypotensive. Imaging confirms a large right-sided pleural effusion. Analysis confirms 5 grams per deciliter of protein in the pleural fluid, while only 9 grams per deciliter in their actual serum. The pH of the pleural fluid is less than 7.23. Which option below is the most likely underlying etiology? Is it A, none of the above, B, bacterial infection, 3, underlying heart failure, this patient does have a history of CHF, and 4, cirrhosis, again, something that this patient has a history of. So what are the hints here? Well, we have a single-sided pleural effusion in an obtunded and hypotensive patient with CHF and cirrhosis. A hint here is 5 grams per deciliter in the pleural fluid and 9 grams per deciliter in their serum. So, based off those protein analyses, is this transitive or exudative? That's our first hint. And because the protein is greater than 50% when compared to that in the serum, it is an exudative fluid. Another hint is that the fluid pH is less than 7.23, which is, again, a finding that you'll find in bacterial infections, pretty severe ones if it's less than 7.2, often signifying something like empyema. So we have a couple hints towards bacterial infection that are also obtunded and hypotensive, maybe in the setting of septic shock. So although CHF and cirrhosis can lead to pleural effusions, they're often transidative in nature. CHF can lead to bilateral pleural effusions as well. So in this case, I think bacterial infection is the best answer. And if you come up here, here's Light's criteria where you can see how you differentiate between transidative and exudative. It's based off the protein ratio, the LDH ratio, and then if you're greater than 2/3 the upper limit of normal, in regards to LDH, you can also find the exudative or transidative differentiation here. All right, this is important to know both for the boards and the wards. All right, next question. So, a patient being treated for new tuberculosis diagnosis presents to the ED, frightened after working out and noticing her sweat change color. Which medication is the underlying cause of this manifestation? So, this is kind of you know it or you don't. Which of these 4 meds, rifampin, pyrazinamide, ethambutol, and isoniazid, cause changing of bodily fluids? Changing of color, excuse me. And the answer is rifampin. Remember, it can change your tears, your sweat into kind of an orange color. Pyrazinamide would be the correct answer if someone was having maybe a uric acid crisis. Ethambutol, anything vision changes, you think ethambutol. And isoniazid, we've talked about it in the setting of peripheral neuropathy on our podcast multiple times. We talk about it in the setting of sideroblastic anemia. We talk about it in regards to you needing to supplement with B vitamins, and then also hepatic damage. So a couple of things for isoniazid, probably the highest yield of all of them. Rifampin is the one that does change the color of your body fluids, and is also the one that can induce P450 in your liver. All right, a child presents with a red, beefy pharynx and the sniffles. You're pretty sure the etiology is blank in nature, bacterial or viral. What do you think? Well, if you chose viral, you'd be correct. And here are a couple hints. One, viral is often the most common cause of pharyngitis, period. So if someone just walked into your office and they had a sore throat, it's most likely viral. Hints that it's also viral in this vignette are the sniffles. Sniffles are actually something that you look for to rule out a bacterial pharyngitis. So if someone came in with sniffles, that would actually be a good sign against, say, a strep pneumo infection. So, red beefy pharynx and sniffles, viral infection. The next question. For a patient with latent TB, isoniazid for 9 months is an appropriate treatment. True or false? So I almost didn't put this one in because treatment regimens tend to change pretty frequently, and what's preferred often differs across providers. But I thought this was a cool just teaching point, is that isoniazid by itself for 9 months is appropriate for latent TB, which is TB found via blood analysis, but it's not, the patient's not symptomatic, there's no findings on chest x-ray, it's just that they had a positive TB test. So isoniazid for 9 months is appropriate. You can also do rifampin for 4 months. You can do rifampin and isoniazid for 4 to 6 months. So there are a couple different regimens. It's typically either going to be isoniazid by itself, rifampin by itself, or the two combined together. The wrong answer will be the entirety of RIPE therapy. All right, next problem. 76-year-old man intubated due to COVID pneumonia is improving after 10 days when all of a sudden he begins to suspect new fevers. You suspect a hospital-acquired bacterial pathogen, pretty specific, and you decide to empirically treat for what? The answers are gram-positive rods, gram-negative rods, gram-positive diplococci, and mixed flora. So these are tough, so let's run through them one by one. So just in general, the picture looks like an elderly gentleman with COVID, intubated in the hospital, new fevers, getting worse after 10 days of improvement. So we're not thinking this is COVID, although COVID could do that. So you were suspecting a bacterial pathogen, so there's no ambiguity there. And the first option is gram-positive rods. So gram-positive rods are tough. I mean, you're not thinking about staph or strep in this case. You're thinking about more rare organisms like Clostridium, but nothing jumps to mind right now that I would be worried about in a hospital setting for gram-positive rods. So skip that for now. Gram-negative rods. Gram-negative rods is something I'm always thinking about in a hospital setting. It's something that you should consider. We have Serratia, we have Pseudomonas, we have a bunch of bad players that are often associated with someone that's been on a ventilator for quite some time. So that's not a bad answer, and we'll keep that for now. Gram-positive diplococci again. I think about Enterococcus among other things, GU, GI, nothing that screams intubated COVID patient. And then mixed flora. Mixed flora very well could be it. Let's say if this patient came in and they were altered and there was concern for aspiration, mixed flora would be an appropriate answer. But because this person's been intubated for 10 days, we get no indication that there was an aspiration event during this time. There's no signs that there were residual tube feeds coming back up the GI system, nothing like that. We don't really have a good hint, although it's never a bad option to consider aspiration. So out of all these answer choices, gram-negative rods is probably the best answer choice here because of the association with gram-negative rods in a hospital and specifically in intubated patients. So always think about that, gram-negative rods, if someone that's intubated is getting worse. All right, next question. A mother presents to the clinic with her newborn infant, recently diagnosed with cystic fibrosis. She's an ED tech and is curious regarding what underlying bacterial pathogen she must be concerned with as her child grows up, both in childhood and as a young adult. The best response is, well, is it child Staph aureus adult Pseudomonas, child Pseudomonas adult Strep pneumo, child Pseudomonas adult Staph aureus, child Strep pneumo adult Pseudomonas? So if you're just listening to this, not looking at our screen here, that'd be a little daunting and confusing. So basically, what bug, let's break it down, what bug are children with cystic fibrosis most likely to battle in their lungs when they're a child? The answer, Staph aureus. How about when they become a young adult? The answer then shifts to Pseudomonas. To show that, we have a chart right here showing just that. So the green line here is Staph aureus, and you can see that it's highest when the children are young, and then around their teenage years it starts dropping, and the red line, which signifies Pseudomonas, starts rising. So about mid-teenage years, Pseudomonas becomes the main player in regards to bacterial incidence in those with cystic fibrosis. So almost 80% of patients by the time they're 25, 35, Pseudomonas is the main player. All right, and then final question for this round. How about a patient comes to your office with 12 hours of myalgias and fevers. They are influenza positive. True or false? There's a role for oseltamivir in this patient. So oseltamivir is a controversial med, but there is research and good research that shows that if you use it early, it can actually decrease the duration of symptoms in patients. So how early is early? I would argue that most people would say within the first 48 hours of symptoms, you can give oseltamivir or Tamiflu, and it would help someone with influenza. So since this patient came in with 12 hours of myalgias and fevers, oseltamivir would likely be useful in them. So the answer would be true. All right, guys, I hope this was helpful. We'll run through the next couple problems in a subsequent video. If you have any questions, concerns, or if you're thinking, hey, this could be a better video if you did XYZ, reach out. We have a social, we have an email, we have a website. Feel free to come explore our website as well. We have an Ace the Board section where you can see our podcast called Buzzwords, the Med School Drinking Game. We have a brew review where you can look at all the brews that we have during that podcast. We have multiple practice exams. We have a Discord. We have Alexa apps that quiz you on material. We have an interview section, a Buzzwords Med store with some cool posters, among other things. And then if you want to reach out to us, as always, there's a chat function there. Alright guys, until next time, have a fantastic day and a wonderful rest of your week, and we'll talk to y'all soon. Bye-bye now.